Welcome to my poster. My name is Mark Lavelle, and I'm presenting a study that's part of a larger ongoing project investigating the visual interpretive behaviors involved in diagnosing breast tissue biopsies. Rather than viewing traditional glass slides under a microscope, the pathologists enrolled in our study viewed digitized slides on a computer screen, and that allowed us to track their eye movements as they evaluated and diagnosed the breast tissue biopsies. As you can see in Figure 1, the pathologists could zoom in and out, and they could also click and drag the tissue to evaluate different regions when they were zoomed in. We wanted to leverage prior categorizations of strategies in medical image perception to see if different strategies in pathology would be associated with different levels of accuracy. In particular, we adopted the driller versus scanner framework developed for radiologists viewing CT scans to diagnose or to detect lung cancer nodules. Drillers would keep their eyes in a relatively stationary position and would move through the cross-sections in a rapid sequence. Scanners, on the other hand, would look at multiple regions of each cross-section before moving to a new one. Drillers had higher diagnostic accuracy and higher levels of experience within radiology, and therefore we predicted that drilling within pathology would be associated with greater diagnostic accuracy. Figure 3 demonstrates how we measured drilling and scanning. We had to contend with the fact that drilling was defined for three-dimensional CT scans, whereas biopsies are only two-dimensional. So rather than movement through the depth of the CT scans, we measured the movement through zoom level as the defining feature of drilling. The data from the pathologist above shows the zoom level and the coordinates of each fixation as they evaluated this case on the left. And the pathologist above had the highest drilling rate for this case. Drilling rate we measured as the rate of movement in zoom, and you can see this pathologist was zooming in and out almost the entire time they were evaluating this biopsy. The pathologist below had the highest scanning rate. We measured scanning as the cumulative distance between fixations and scanning rate as just how quickly fixations were moving. Fixations are represented by color, so this rapid change in color here resulted in a rapid increase in this pathologist's scanning rate on this case. Whereas previous work has conceptualized drilling and scanning as mutually exclusive strategies, we measured drilling and scanning independently and were therefore able to explicitly test whether they were related or not. Figure 4 demonstrates that they had a negligible correlation. So we used both variables as predictors of diagnostic accuracy on a case-by-case level. We also evaluated the influence of covariates, including saccadic amplitude, average zoom, and interpretive duration. When evaluating the relationship of drilling rate with diagnostic accuracy, with or without covariates, drilling rate did not have a significant association with accuracy, which was contrary to our predictions and discrepant with prior work. And the reason we think that's the case is drilling plays a much bigger role in diagnostic accuracy in CT because by drilling, lung cancer nodules will pop in and out of view, whereas benign tissue won't pop in and out of view because nodules are only visible on a few cross-sections, whereas benign tissues such as blood vessels are visible on multiple cross-sections. In pathology, zooming in and out won't induce differential magnification of benign versus malignant tissue and therefore may not be as important a behavior for coming to the correct diagnosis. We found significant positive associations with accuracy for scanning rate and saccadic amplitude. When controlling for saccadic amplitude, scanning rate remained a significant predictor of accuracy, and that highlights the difference between these two variables. Whereas saccadic amplitude only measures the magnitude of eye movements, scanning rate took into account where exactly in the tissue that the pathologists were looking. We're not exactly sure why a higher scanning rate corresponds to a higher probability of diagnostic accuracy. But one possibility we're going to explore is whether a higher scanning rate corresponds to a more exhaustive and thorough evaluation of the tissue. We also want to determine whether faculty have a higher scanning rate than trainees, and also whether across residency, trainees in pathology will have a longitudinal increase in scanning. And that's all I have for you. Thank you for your time, and I look forward to your questions and your comments.